think I'll get started. Welcome all attendees to our ORNAO Solventum sponsored webinar this evening. Thank you so much to our guest speakers and Solventum for their support. Tonight's webinar will be discussing reducing surgical site infections, maximizing the benefits of skin antisepsis and decolonization protocols. We are absolutely delighted to have Christine Erickson and Cathleen Ferguson with us this evening. I'll do a quick intro for both before I do hand it over to our speakers. Many of you may know Christine Erickson as the medical liaison for Solventum, specializing in perioperative solutions for the US and Canadian market to prevent surgical site infections. With over 25 years of clinical and leadership experience as a perioperative certified registered nurse, Christine has dedicated her career to improving practice standards and promoting best practices in the field. Throughout her career, Christine has held various impactful roles, including surgical nurse team lead in the operating room, surgical nurse, team lead in the operating room, perioperative educator, clinical nurse specialist, and perioperative manager, and most importantly, as a patient. Her experience and dedication in the field have made her a respected figure in the industry. Christine's commitment to professional growth is evident in her active involvement in organizations including CORAL, ORNAO, ORNAC, and AORN, where she has served in leadership positions, including administrator of the Periop 101 curriculum, and contributed as a peer reviewer for industry guidelines, highlighting her dedication to the advancements within the field. Driven by a passion for evidence-based practice and patient care advocacy, she continues to pursue excellence in the perioperative field at Solventum. Christine is also a member of Solventum's Canadian Sustainability Team, further demonstrated her commitment to promoting sustainable practices within the organization. Engaging and learning from others' experience is what inspires Christine. She looks forward to collaborating with you to create a safer and more sustainable healthcare environment for all. Well, that's quite an intro, but lovely and lots of experience. Thank you so much, Christine. And also Cathleen Ferguson. Kathleen is the former manager of the perioperative services at St. Martha's Hospital in Antigonish, Nova Scotia, where she has worked for over 20 years. Kathleen now works as the RNFA and is up north, where it's pretty beautiful but cold. Kathleen has been an ORNAC Standards Committee member from 2011 to 2015, and she was elected to the role of our Operating Room Nurses Association of Canada President-elect in 2013, as well as serving as the chair for the nominating committees from 2014 and 15. Kathleen has completed her second term as our president at the national level. Without further ado, I'd like to wish you both a very warm welcome and heartfelt thanks for your dedication to our practice. Going to hand it over.
Thank you so much, Denise. Hi, everyone, and I hope you all had a great Perioperative Nurses Week last week. I'm going to proceed without my camera because I'm sitting in the pitch blackness. I have zero power at my house, and I'm running this presentation off of a hotspot on my phone. So me with the slides here as we go, so hopefully everything goes off. Next slide, please. So to effectively reduce surgical site infections, this discussion focuses on understanding and implementing evidence-based skin antisepsis and decolonization protocols while evaluating their impact on patient outcomes. Next slide, please. So imagine a future where skin is not a barrier, but a powerful ally in the fight against surgical site infections. Skin decolonization is an important piece in managing patient safety and recovery. And by targeting harmful bacteria, we can enhance outcomes and redefine our understanding of surgical care related to the patient's own skin. So get ready to embark on this journey with us as we begin with a brief review of surgical site infections and the importance of preparing the skin for invasive procedures. So, as you can appreciate, despite advancements in healthcare, surgical site infection remains a challenging and costly problem. And antibiotic resistant organisms, including MRSA, are a global concern. And incorporating preoperative bathing and nasal decolonization with an antiseptic that's supported by guidelines and recommended practices by leading organizations, and also by choosing the best formula of skin antiseptics to meet your patient's needs while following the instructions for use by the manufacturers and knowing when to incorporate an antimicrobial incise drape. Decolonizing the skin and reducing SSI is a multifaceted approach for managing the microbiome. Our skin has a ton of bacteria, Staph aureus and Staph epidermis, which makes it for major infections. So even though we can't sterilize skin, we can lower infection like preoperative bathing, treating the nares, and using antiseptics before surgery. Next slide, please. So let's start with some basic infections. An SSI is an infection in the part of the body where the surgery took place. So basically, there's three types. You have your superficial tissue, deep, which is involving the deeper tissue, fascia, and or muscular layers. And then you have your organ space, which is involving any part of the body that was opened or manipulated during the procedure, organs, or implanted material. And this classification occurs within 30 days of surgery or 90 days if there's an implant involved. And some global organizations even say to monitor for up to 1 year if there's an implant involved. Acquiring a surgical site infection can have devastating and costly outcomes, deeply affecting both our healthcare system and patients along with their families. So there are a lot of variables that can influence whether a patient gets a surgical site infection, and controlling as many of these variables as possible is part of our role as healthcare providers when caring for patients. So this slide demonstrates the Center for Disease Control risk of SSI conceptual formula. So types of variables that impact the risk of an SSI. You have your process variables and your patient variables. And by understanding each, we can determine what can be done to reduce the risk of surgical site infection. So our interventions, such as implementing strict environmental and staff protocols and ensuring patient compliance with preoperative instructions, can make a significant difference in minimizing these risks and improving your patient outcomes. So let's move on to patient variabilities on the next slide. So these include the factors such as age, comorbidities like diabetes, compromised immune systems, obesity, and smoking, etc. While the clinical team can't always control these factors, we can optimize the patient's condition through medications, counseling, and education for both the patient and their family. And although we strive to prepare the patient to surgery to the best of our abilities, we can't always influence all these factors or ensure patient compliance. So the next slide shows us the process variables. And knowing that the number one cause of SSIs are contamination of an incision with microbes from the patient's own skin, and others include microbes from the environment or the surgical team, this adherence to aseptic technique, monitoring the surgical environment, the team, and each member's surgical conscience place such a vital operative practice, as these are risks that we can impact. So the next slide is going to show us some evidence-based prevention strategies to reduce risk of SSIs. And as we all know, there are numerous actions we can undertake to lower the microbial loads. And it's crucial to understand that no single measure alone will significantly reduce the SSI risk. Rather, it's a combination of many strategies that make a difference. And omitting even one of those preventative measures could potentially lead to an SSI. It requires a comprehensive and collaborative approach throughout the patient's surgical journey to effectively prevent infections. And we all play an important role in advocating. And today we're going to be focusing on the skin. Next. So both ORNAC and AORN have sections addressing strategies, and by regularly reviewing and educating and staying up to date with evidence is an important aspect of the perioperative care. So the next slide, we're just going to mention that we're going to start with the preoperative bathing. So we can go to the next slide. Clinical evidence has shown us that the greatest impact on SSI reduction is when both CHG bathing and nasal decolonization are performed together as part of a comprehensive infection prevention strategy. And decolonization of a surgical patient with nasal mupirocin or povidone iodine for cardiothoracic and orthopedic procedures was reclassified from an practice in the 2022 SHE and IDSA and APIC guidelines. The short-term use of nasal mupirocin is still the most studied and in eradicating Staph aureus nasal. However, increasing mupirocin resistance remains an ongoing concern and newer agents are needed. Therefore, it's important to explore other options that are available to combat antibiotic resistance and compliance. The IPAC recommended 2013, so the APIC ones as well. Next slide. So our global agree on preoperative bathing, which advises patients to shower or bathe full body with soap or an antiseptic agent on at least the night before the operative day. In addition, a preoperative bathing protocol for the day of surgery at the facility should be in place and include at-risk minimum high-risk procedures such as cardiothoracic, orthopedic, and neurosurgery. There should be clinical protocols and policies in place to facilitate this for each patient, along with patient education to help them understand why it's an important part of their upcoming surgery. ORNAC recommendations are also aligned with Health Canada and the global guidelines. So once we pre-bathe, decolonize the nares, there's a potential for hair to be removed from the surgical site. Guidelines for the perioperative practice state that hair at the surgical site should be left in place or not removed whenever possible, and patients should be instructed not to shave at home as this can cause micronicks and cuts in the skin, which would be a route for infection. And studies show that hair removal should be done as close to the time of surgery as possible. And here's the funny part, outside of the operating room. I know we all struggle with that. Clipping in the operating room may cause hair dispersal into the airflow and potentially contaminate the sterile field if it remains airborne. And you should only be removing the hair that might interfere with the incision site. Electric or battery-operated clippers with a one-time use recommended for hair removal. Now that we've completed the pre-op bathing and nasal decolonization, move on to surgical skin preps. If you break down SSI and CLABSI pathogens, aureus is the top pathogen for both of these hospital-acquired infections. Staph aureus was the most commonly reported pathogen of SSIs at an overall of 18% and was the most common pathogen for orthopedics and OBGYN and cardiac surgical site infections. So the goal of preoperative skin antisepsis is to reduce the patient's risk of developing an SSI by removing soil and transient microorganisms at the surgical site. And reducing the amount of bacteria on the skin near the surgical incision lowers the risk of contamination at that surgical incision site. So as part of preparing the skin for antisepsis, that preoperative decolonization, the bathing, and the hair management at the surgical site contribute to that reduction in microorganisms on the skin. An effective skin antiseptic rapidly and persistently remove the transient microorganisms and then help to reduce those resident microorganisms to subpathogenic levels with minimal skin and tissue irritation. So as healthcare practitioners, it's crucial to understand the baseline considerations for PrEP selections to ensure patient safety. And key factors include checking the patient for allergies and sensitivities, considering the patient's age, especially if those are under 2 months of age, assessing the condition skin, and being mindful of the incision or the insertion site. And additionally, understanding the active ingredients in the PrEP and selecting the appropriate single-use applicator for the procedure are essential to avoid complications and ensure that you're following the manufacturer's instructions for use and know those contraindications related to each formula. So the clinical guidelines recommend the use of an antiseptic PrEP that contains both alcohol and a second active ingredient if indicated. And looking across those global clinical guidelines, we see that the consensus for surgical skin preparation recommendation is to use a skin prep that contains both alcohol and a second active ingredient. And we have to always keep in mind that there is no one prep that can be used for all surgeries. And ORNAC also supports all of them. Clinical guidelines also recommend the use of single-use containers versus multi-use bottles to reduce that potential of contamination. That's also in the ORNAC guidelines. So not all skin preps are created equal. There are three active ingredients most commonly used in North America. You have your alcohol, your CHG, which is known as chlorhexidine gluconate, and your iodine. So the first one on the far left is your isopropyl alcohol. It's the most rapid acting antiseptic and achieves the greatest reductions. It dries rapidly, but it has no persistence. It's also flammable, so it must be used correctly in the OR environment, and it is contraindicated. The next one is our CHG, or chlorhexidine, and it's been increasingly used since the 1950s. It has a greater persistence and residual activity than any other antiseptic. It has a low skin irritancy and good broad spectrum kill of organisms. It's not absorbed through the skin. It's not inactivated by blood or serum proteins. However, CHG is neuro and ototoxic, so you need to avoid contacts with the meninges, the eyes, and their inner ears, as this can cause serious and permanent injury. Then you have your povidone iodine, which is free iodine is the active ingredient and is an unstable and highly irritating molecule. So that's why it's suspended in a polymer, which in this case is the povidone, to make it a more usable solution. A 10% povidone iodine usually contains 1% of free iodine. But you have to keep in mind it has minimal persistence, but it has good broad spectrum coverage. And application time to effectiveness can be as long as the time as it takes for the free iodine to work. And it also takes a long time for it to dry on the skin because it's an aqueous prep. It is only active when it's visible on the skin, and it's also known to be a skin irritant and is easily absorbed through the skin and mucous membrane. It's neutralized by organic material, and there are contaminated solution as most products are available in bulk bottles. So back to that guideline stating that single-use containers are what is recommended, and this is why. It also has the potential for endocrine effects, which would be related to the extent of the systemic absorption and would be related to the duration of topical exposure. Other iodine solution, it's called iodine provacrolax. It provides a rapid, spectrum antimicrobial activity. It immobilizes bacteria remaining on the skin. It's water insoluble film, and it resists wash off by irrigation fluids, blood, and saline. It's recommended to be left on the skin and gradually wear. In its formula, it improves and enhances drape adhesion. And because of that formula, it really done at a faster rate than the aqua preps. And it's been around since. So I just want to clarify between those two iodine, povidone iodine is not iodine provacrolax. They are different and they are similar. So the similarities are that they both release a free elemental iodine. They both have a carrier complex, which helps to reduce the irritation potential of the iodine on the skin. The carrier complexes also enhance sustained release and persistence of the iodine. The differences, however, are the povidone iodine carrier complex is povidone, which is water soluble and susceptible to unintended removal during surgery. So it can be removed by blotting with a sterile towel. It may be removed by blood or saline or wet sponges. Whereas the iodine provacrolax carrier complex is a provacrolax, and it dries to a durable, water insoluble, water resistant film. And it protects the iodine-based prep from removal during the surgery. And it also immobilizes the bacteria remaining on the skin, enhances drape adhesion during the surgery to conception is iodine allergies. So iodine is a trace element that's essential to life and present throughout our bodies, and true allergy to iodines do not exist. A very small number of patients who are extremely predisposed to allergy may exhibit sensitivity yet there's no correlation between reactions of iodine and allergy to fish or seafood. Contact dermatitis related to topical iodine antiseptics is not an indication of an iodine allergy. Rather, it's an indicative of a reaction to the chemicals that are in the product. An anaphylactic reaction on a topical iodine antiseptic solution is exceedingly rare and not proven to be related to iodine. So it's really important to explore what the actual allergy is and if it has been sorted out with an allergist to determine what exactly is causing the allergy, because it's likely not iodine. So this is a study that talks about the iodine provacrolax and how it resists wash off and remains persistent for 48 hours. The objective of this study was to evaluate the durability of the antimicrobial effectiveness of the DuraPrep, which is the iodine provacrolax surgical solution, following a blood and saline challenge by measuring the regrowth of normal skin flora on the human back at 48 hours post-prep. So the methodology they used was baseline bacteria counts were taken on the backs of 10 healthy volunteers, and then the DuraPrep surgical solution was applied and allowed to dry. And then post-prep counts were taken 10 minutes after the prep dried. Half of the remaining prepped area was then challenged with blood soaked gauze, followed by sterile saline soaked gauze. And after the blood and saline challenge and post-prep sampling was again performed, the remaining sites were covered for 48 hours. After 48 hours, the coverings were removed and the test sites were sampled. All samples neutralizing solution, and their findings found that DuraPrep surgical solution suppresses regrowth of bacteria for at least 48 hours with and without a blood saline to simulate those surgical conditions. So you get that persistency with the iodine. So I wanted to share this video that the New England Journal of Medicine posted. This is Dr. Flannery. He's an American comedian and posting 2016. This is a skit in regards to the next study I'm going to show you. So if we could just play the next slide.
Hey, Ortho. Oh, what up, bug bro? Did you... Antisepsis? Nah, bro, I've been pretty busy over here. Oh, okay, well... It involves fractures. I'm listening. We randomized over 9,000 fracture patients to receive preoperative iodine or chlorhexidine. Different types of topical antisepsis. Ancephalocin. Oh, cool. Anyway, turns out the iodine group had fewer surgical site infections. What kind of extremity fractures were these? Were they open or closed, bro? Bone sticky outie. Oh, both were included in the study, but only the closed fracture group was statistically significant. So according to this study, it would be best to prep all my closed fracture patients with iodine? Yeah, you should also carry around an antibiogram. Here, I brought an extra. Oh, I already have one, thanks. Oh, okay. Well, see you later. Later, bug bro.
You can go to the next slide, Troy. Thank you. If you don't follow that guy, he's pretty funny. You might want to follow him. So this is the study that he's referring to in that skit. I'm comparing a DuraPrep to CHG with isopropyl alcohol, and it was published in the New England Journal of Medicine in February of this year. The purpose of this study was to determine the superiority of either the 0.1 iodine provacrolax and 70% isopropyl alcohol, which is the DuraPrep and the iodine group that he was referring to, versus the 2% chlorhexidine gluconate and 70% alcohol, so the chlorhexidine group, as a skin antiseptic for surgical procedures to repair extremity fractures. The study design was a clustered randomized crossover trial at 25 hospitals in the United States and Canada. The methods were that the participating hospitals alternated the interventions every 2 months between September 2018 and December 2021. The separate populations of patients were either open with an enrolled and included in the analysis. The primary outcome was surgical site infection, which included superficial incisional infection within 30 days or deep incisional or organ space infection within 90 days. The secondary outcome was unplanned reoperation within 365 days for fracture healing complications. And their results showed that in patients with closed fractures, the risk of surgical site infection was 20 Antisepsis provided by the iodine provacrolax alcohol than that by the chlorhexidine gluconate and alcohol. And no difference was found in the open fracture surgery, most likely as the open fractures are exposed to bacterial contamination before surgery. And because of this pivotal study, you may see changes in the skin antiseptic choice for extremity surgery. Next slide. So dry time of your skin antiseptics, allowing that antiseptic solution to air dry completely on the skin is crucial for the patient's safety and efficacy. The drying time depends on a host of factors, presence of hair, the skin type, etc. And proper drying ensures the antiseptic adheres to the skin and reduces the risk of skin irritation, and it prevents complications like dripping or pooling under the drapes. And also in environments with ignition source use, such as the operating room, a full 3 minutes of dry time is essential to prevent fire hazards or sentinel event. So what's next? Antimicrobial incise drapes. So antimicrobial incise drape, patient with your pre-op CHG, your nasal decolonization, skin antiseptics, and now if surgery. So what does that mean and why is it important? Antimicrobial incise drapes have been around for over 40 years. And aspects of a PrEP is that the PrEP remains effective throughout kill the microbes that are on the skin. So why is this a concern? Because the PrEP is subject to surgical activities or challenges, and some PrEPs are water soluble or aqueous, which means that they can be easily washed or rubbed off during the surgery. And PrEPs can also be removed during surgery by activities that can impact or PrEP's ability to skin. These include activities such as irrigation, dabbing, your surgical sponges or gauze, your body the skin surface, and manipulation of the tissue and surrounding skin by instrumentation and retractors. So essentially everything we're doing during surgery. When a PrEP washes off or is removed, this reduces the ability of the PrEP to keep killing those microbes throughout the procedure, putting your patient at using an antimicrobial drape can aid in maintaining that residual kill. Next slide, please. Residual microbes that survive on the skin surface because we can't sterilize. And then in the hair follicles, we cannot sterilize that skin. So additional protection bacteria from the hair follicles that migrate to the skin surface can be picked up by items that touch the skin, like by things like gloves, instruments, sponges, bodily fluids, etc., and transferred into the incision, increasing that patient's risk of skin of infection. And as you can see on this slide, the skin antiseptics, they penetrate to about 300 microns, whereas the antimicrobial incise drape reaches about 1,000 microns for up to 6 hours while it's on during the procedure. Next, so why is this important to you and your patient? Some surgeries have such close proximity to that exposed skin and close to the implant site, and the ability to protect that exposure and immobilize around it is crucial, especially with high-risk surgeries that involve, like ortho, that have implants. So that we can't sterilize the skin, and it takes as little as 10 of those microbes that are on the skin to cause an SSI. So we're trying to keep that out. What we're seeing here on the screen. This is about this. Next slide, we have over 4 evidence The IABAN2 antimicrobial incise drape study, public and economical results across a broad range of evidence ranging from poster presentations, randomized controlled clinical global meta-analysis studies that are available. And I'm happy to share any of our studies with you. If you want, you can just shoot me an email and we will share any of our publications so that you can review them yourself. And the next slide is just showing us our global guidelines for surgical incise drapes. And these are just some of the guidelines regarding, but one thing they all agree on is that if you are using an incise drape, please ensure that it has antimicrobial properties in it. So having explored the foundational aspects of our clinical practice, it's now time to dive deeper into the practical implications of our efforts, and Cathleen will share valuable insights, experience, and provincial policy, highlighting how initiatives based on NISQIP data have led to a significant reduction in surgical site infections following the implementation of a comprehensive bundled intervention. So thank you for being curious about your practice and advocating for safe patient care. I'll pass it over to Cathleen to discuss how her team tackled this topic and improved their outcomes through SSI Prevention Quality Improvement Initiative.
Well, thank you very much, Christine, and thank you so much for your presentation and sharing that important information that's so relevant to our day-to-day work. I'd like to say a quick thank you to Solventum and RNFA for inviting me to speak tonight on our experience. So I'm going to turn my video off. Thank you. So that's just a disclosure that I am a speaker for Solventum. So as perioperative nurses, ours is an evidence-based practice. And as we all know, we follow national perioperative standards and guidelines. In Canada, it's ORNAC, and our guidelines compared to those in other countries, AORN in the States, ACORN in Australia, for a couple of examples. And the reason our standards are so similar is because they're based on the same evidence and research. So why are these nursing practice standards so important? Well, they're important because they provide us the foundation as perioperative nurses to deliver safe, effective, high-quality care to our patients. And by adhering to these nursing practice standards, it's also critical for professional growth and development of us as nurses. And as Christine has pointed out, the ORNAC guidelines, section 2, is about infection prevention and control, and specifically 2.19 is on skin preparation. And everything that Christine has presented tonight is supported in these standards. And the ORNAC standards also support the SSI bundle, which we are all also very familiar with. And on the next slide, we will see the components, and I think you're all familiar with this. So it includes the antiseptic use, both pre-op and intra-op, and appropriate hair removal, which Christine has spoken about. And it also includes the timely administration of antibiotics, maintaining normothermia, peri-op, and perioperative glucose control. ORNAC standards also refer to a specific bundle, which is from CPSI. And that CPSI is the Canadian Patient Safety Institute. And they've changed their name, so they're known now as Healthcare Excellent Canada. And Safer Healthcare Now, the objective of CPSI was to raise awareness and to help facilitate implementation of best practices. Next slide. So Safer Healthcare Now was a Canadian campaign, and the goal was to help organizations to implement best practice so that they could achieve improved patient outcomes. So next. The first kits were actually released in 2005, and I can actually remember when this first kit was released, and that's probably because I've been around a lot longer than most of you that are in the audience tonight. It was entitled Prevent Surgical Site Infections, Getting Started Kit. And the next slide will show you section B of the kit. This was actually archived, you probably can't read in the bottom, by CPSI in 2014. And if you can see, even back then, it was recommended, as Christine has pointed out, that the patient should shower or bathe the night before with soap or antiseptic agent, either the night before or the operative day. It refers to using the alcohol-based prep, and it also talks about the 3-minute dry time. So this information has been around for a long time, but it's still very relevant to our practice today because the research and evidence still support these best practices. So next. So how do we know that we are meeting these standards and we're performing our best practices? Well, we know this by quality assurance. The quality assurance programs help us ensure that we are implementing high standards of perioperative care. Quality assurance allows us to compare ourselves to standards or benchmarks. That benchmark could possibly be another facility that's the same size, similar to our own. It helps us identify problems and use corrective actions, but it also includes continuous training of staff. I work mostly in general surgery and plastics, so I was aware of this symposium that took place in February of 2018, and it was put on by CAGs, the general surgeons, and they were looking to develop a Canadian strategy for surgical quality improvement. So the next slide will show the 6 principles that they came up with, and I think these are really important. They did identify that a Canadian quality improvement strategy was needed, but they also identified that it doesn't just include continuous data collection. It needs intentional effort. So data alone will not drive improvement. There has to be increased focus on standardization, and process improvement may be necessary. And they did also identify in the 6th principle, which is relevant to us in Nova Scotia, because we have quite rural hospital, a lot of rural hospitals. Where I work at St. Martha's is a rural hospital. And it was very important for us to identify champions. Champions are so important in any program that you want to implement. So we identified surgeon champions and also anesthesia nursing champions as well. So in Nova Scotia, we adopted NSQIP throughout the whole provincial authority. We're all one provincial authority now. And I'm guessing that a lot of you attendees tonight are familiar with NSQIP, because I know it's quite popular throughout Ontario as well. NSQIP not only includes auditing your data continuously, but what I really like about it is the 30-day post-op tracking. So 30 days post-op, the patient actually gets contacted and interviewed. And that patient feedback is so important, and it gives you so much valuable information. You can find out how your program's doing and are you really implementing the best practices. NSQIP also includes team engagement, and it promotes best practice in peri-op. Next one. So I just put a little map up here to show you where NSQIP is across Canada. And this map is a little deceiving, because if you look at Ontario, it looks like there's only 1 or 2 H's, but actually, because the area is so close together, there's a lot of H's. So NSQIP is quite spread out throughout Ontario, as well as Nova Scotia, you can see, and also Alberta and BC. So we initiated NSQIP, and unfortunately in late 2020 and the beginning of 2021, our data triggered, and we triggered red for SSI. And this was quite concerning. So we tried to find the reason why. Why do we have this big spike? And we honestly could not find one specific reason. So we decided that we were going to go back and we're going to tighten up our bundle. So that's what we did. We took a bundled approach to preventing SSIs. And as you can see, we concentrated on the components that I mentioned earlier with the SSI bundle. Next. So we took a team approach. And again, as I said, we identified our champions to help. So what we had to do was increase awareness. So we shared the data, shared the audits, our SSI rates. We did some education. We did in-services, poster presentations, reviewed best practices. But I think the one thing that hit home for us in our OR was we had a presentation by a plastic surgeon. And, you know, the patients come into our operating room. We take great care of them. Then they go to recovery and then they're gone. We don't see them again. You very rarely hear back how your patient's doing. But the surgeon has to deal with that surgical site infection. And this plastic surgeon, when he did his presentation, he reviewed cases. Most of them were breast reconstruction cases. And he went into detail on a couple of patients that got an SSI. And he had pictures and he told the story and how it affected their lives, how it affected their work, you know, dealing with their families. And I think it just hit home that everything that we do is so important. Every practice that we do is so important. And we may not see the outcomes, but these audits that we do and these numbers really mean a lot because there's a patient attached to those numbers that's suffering at home with that SSI. So we decided to focus on standardization, as I said, was mentioned at the symposium. So we decided we were going to come up with a provincial policy. So we did develop one, and that was back in March 15th of 2021 that it was released. And it was entitled SSI Prevention Guideline. So this was put into place across the province. And at our site, this was put on every computer in the OR and recovery room. And on the next slide, I'll just give you an example of what was included in the policy. I won't go through the whole thing, but it did include the skin preparation best practice. And this is all what Christine has already mentioned. But I just wanted to note at the bottom that I highlighted in yellow that there's a link. So if you open the policy, you can click on the link and it will take you to the next slide. And that's to the skin prep portal. And I'm guessing that a lot of you have seen this, but we've made it readily available to the staff. And as most of you probably know, you can go in and look at the site that you're going to prep, and it helped guide you along. And provincially, we did switch to SoluPrep, and that's what we use at our hospital now. And we use the sponges, which you see in the picture. So next. And we also talked about if you can't use the chlorhexidine, which Christine has already spoke to. And then the next slide will show the appendix at the end of the policy. And this is really a nice summary of your skin prep recommended procedure. And again, we do have the link at the bottom that's easily available for staff to look at. And it's always important to have patient education. And at our site, the patient education actually takes place in the pre-op clinic. So they are told to shower or bath the night before with the chlorhexidine wipes. And of course, it's always important that they check with the patient regarding skin sensitivities, allergies, and possible open wounds or cuts near the surgical site. And I just wanted to share this picture with you. And again, I just wanted to stress that the patient feedback, when we get the feedback from patients, we get information about different phases of their perioperative journey. And feedback about the patients can help motivate you. And this patient in particular was one of our first ERAS patients. And as you all know, ERAS promotes best practices as well. And this gentleman actually got out of the hospital day 2 post-op. And it was just interesting to see how excited the staff were when they saw how well he had done after going through the ERAS program. And it just helps motivate you when you see how well the patients do. Next slide. So I think this graph here pretty much sums up our story. And you can see where we spiked. And then after implementation of the policy, you can see how our SSI rates went down significantly. And the only thing we did was implement the policy and tighten up the phases of the SSI bundle. So the lesson we learned is that everything that we do is important, from the prep to maintaining normothermia, etc. All those, each step in that bundle is so important to the patient's outcome. Next slide. So our evidence, these best practices that we do as perioperative nurses come from our ORNAC standards, our NESQIP guidelines, the ERAS guidelines, and as I said, the SSI bundle. So the challenge to improve quality of surgical care doesn't have to be discovering new knowledge, but rather how we integrate what we already know into practice. Next slide. So I just wanted to mention self-evaluation. And self-evaluation is a process of thinking about how you've performed and asking yourself questions on how you can improve. And I've been a perioperative nurse for over 35 years, and I've worked in many roles along the way. And self-evaluation, self-reflection is so important. Reflection allows us to grow and to find meaning in the work we do. And it helps us reconnect with our passion and improve the care we provide. And just every now and again, it's good to just step back and look at yourself and just do some self-evaluation, some self-reflection. And the next slide. Oh, so to unlock your full potential of your nursing practice, reflect on your performance and identify areas of improvement. And I just want to applaud you all for attending tonight. You're showing your dedication to keeping up with your practice and refreshing and learning new things. So I just want to say that's so important. And you got to keep fueling your passion. And that could be education, like tonight, or attending conferences, like the ORNAC conference coming up, workshops, getting your certification, learning new skills, celebrating successes, celebrating on Perioperative Nurses Week. I don't know if you did, but I hope you did something. And like the picture of the patient that I showed, celebrating the success of the patients. That's all great to fuel your passion. Being a mentor, being a leader, advocating for your patients, all ways to refuel your passion. Keep shining in every task, every patient. You're not only nurses, but you're our life changers. But don't forget that you have to take care of your self-care, take care of yourself. That really helps you refuel your passion. We're so good at taking care of our patients. We're so good at taking care of others. But as nurses, we're not always good at taking care of ourselves. So the next slide, I just wanted to say thank you. And I wanted to share what fuels my passion and my self-care is spending time with my daughter and my granddaughter at the barn. So I'm sure there's something that fuels your passion as well. So I just want to thank you so much for your time and listening to my story. And thank you very much.
Well, that was simply amazing. So much information to think about. You've certainly given me some things to think about. So thank you for expanding my understanding for starters. Lots of data. I put in the question around inside drapes, and we'll look to see if there are any other questions. You can certainly put your questions in the Q&A as well as the chat box. So please feel free to do that. I did not see any. So in the interest of starting the discussion and hoping to generate more, I've got a couple of questions to ask. So recommendations with respect to urgent emergent. So I'm thinking about patients that may present through the emergency room and not follow through that normal preoperative clinic sort of planned pathway. Recommendations when we don't have time to necessarily do that night before shower or decolonization, or even swab them and have the results back before surgery happens. Any comments on that?
There's a couple of things that you can do. There are some manufacturers out there that better term right now. So that can give a quick wipe down just to get some of that off the skin to initiate that bathing, and it's quick and simple and easy to use. So that is an option. I mean, when we're in an emergency, obviously we're going to do the have at that time, and life and take priority over the decolonization. But we got to do trying to decrease resident and transient microbes on the skin. When you talked earlier about that, they're not always coming through that pre-admission process or coming opportunity where the periop can educate the other units on the importance of decolonization, waiting in those areas before they send them up to the OR. Is there starting with the dirty, we're going to be creating that incision that's going to introduce those microbes into the body. We want to do our best to try and decrease the microbe on the skin as much as possible, but educating and letting them know the impact that it makes by having, you can have a protocol or some kind of order set maybe in place that can help direct units outside of the operating room that aren't as familiar, I think are good tips there.
Those are excellent suggestions. Thank you, Christine. It sort of makes me think about the team building between various units that support or send or receive patients from the OR. It's not something we've done in our organization specifically. What I have seen recently as this past weekend, we had a great conference called Cutting Edge. And some of our surgeons did speak to that in terms of ERAS, et cetera. So I think there may be some opportunity there to build a tighter team that's all on the same page. So really great suggestions. I do see a question here from one of our members here, our attendees. What prep would you recommend for traumatic large open wounds?
So again, a tricky question because all of the skin preps, if you look at the manufacturer's instruction for use, they all say to be used on intact skin. So that's where we need to have individual conversations outweighing the risk versus benefit. Definitely, we know we're not going to be putting any alcohol or CHG on an open wound. And the ways that I can help with that is if you provide me your email, I can share publications on aqueous solutions that have been used off-label, we're going to call it, or not specifically indicated for use, because like I said, intact skin, to look to the publications and the evidence that's out there and what have people in the past and what kind of outcomes did organization to make that informed decision on how I want to proceed with it out and to easily follow as well.
Yeah, and I do recall when I'm from the Hamilton area, so large academic center, but lots of fractures at the general. But some of our orthopedic surgeons in particular would choose to do an alcohol CHG solu prep because they knew that they were going back to debride that open wound. So, I mean, I'm not saying that it's it's indicated by the manufacturer, because it certainly is not. But sometimes the surgeons do have these thoughts, right? And they follow it through to help sort of prevent that osteomyelitis, et cetera. So I guess it probably is a team by team discussion, but interesting, great question for sure, because we raised that a lot when we started to see that practice, and we had concerns from a nursing perspective. We have another question here from Sarah, and Sarah's asking for hair clipping. Was there a difference with the surgeon shaving, or it should be clipping, the patient day of surgery versus the patient at home prior to, and really the questions around an increased risk of SSI taking place?
Yes,
Any
again, I could share publications on that as well. Knowing what we know about the human microbiome, and that we have cells on our body versus 100 trillion that include bacteria, virus, fungi, etc., that are on our bodies at any given time, and it takes as little as 10 of those microbes per centimeters to get into that incision to create a infection, is the reason why we're trying to decolonize this. And if somebody is ahead of time or creating those nicks in the skin, they're increasing their chance of getting that bacteria into the skin near the incision site before we even get started. So that's why it's highly recommended that they don't do that. And if you're interested in public research, and share those with you as well.
Excellent, thank you. I know that we've had some patients think they're helping and shave the, do whatever their hygiene routine is the night before, and then they're plan to have an orthopedic hip procedure, and they've been canceled because the surgeon does not want to take the risk.
Exactly. And
Yeah.
that's why it's really extremely important. The most important person that needs to be engaged in all of these things is your patient, and helping them understand why we do what we do and the importance of why we do what we do. Because just like you said, Denise, I think a lot of them think they're helping out, or that they're trying to expedite things, and actually they're potentially creating harm for themselves. So education, 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 conversations, listening, and having those conversations with the patients and families, and teaching them proudly what we do.
Absolutely. And that pre-op clinic piece, I wonder what the education, sometimes if it's up to what it needs to be. So great things to explore and ponder. We have another question here from Candace. And Candace is asking, I've learned recently that new cat scratches before surgery are also a risk factor for SSI. What are your thoughts? Any thoughts on that?
I don't have any specific research study read on cat scratches, but I'll look, maybe there is. However, it just makes sense, back to my previous point, that if we're creating issues on the skin surface, which is our main barrier and our main protectant, anything that is disrupting that skin barrier and allowing bacteria in is going to potentially contribute. So yeah, that's a good point.
And we have a question in the Q&A from Selena. Is Ioban antimicrobial drape recommended for laparotomy / bowel resections, as well as orthopedic surgeries involving implants?
Sorry, I'm trying to find it because you cut out. I didn't.
Oh, I'm sorry. I can read it again. Basically,
Okay.
Ioban incised drapes, are they also recommended for laparotomy / bowel, as well as implant in orthopedics?
An antimicrobial incised drape could be used really anywhere on the body. There's no restrictions there. They just tend to have always been his orthopedics. And a lot of times it's from their mentor, whoever
Yeah.
used it, then they kind of adopt that as their practice. So definitely it's something that can be explored. And again, I'm happy to share publications on surgeries outside of orthopedics that have used antimicrobial incised drapes, because there is evidence of.
I recall that back when I first started a couple of decades ago now, I feel like incised drapes were more than routine. And I feel like they've sort of fallen away and now they're making a resurgence. Is that sort of close to being accurate in terms of what you're seeing as well, Christine?
Yeah, I mean, they've been around 40 years. And I mean, I know when I first started in the OR, totally understand what they were for or what the purpose was. These preface. So I've learned a lot about them now. All are the skin antiseptics go down to 300 microns, and then the extra barrier of having an antimicrobial inside even deeper to the 1,000. With those, that resident micro able to sterilize our bodies. So we're just trying to reduce the risk as much as it's just another like I said on that one slide where it had all that many multiple interventions that we do to be. I see also there was a question about does DuraPrep come in bottles? No.
Yeah.
Applicator size, single use. The outer container is, or like the applicator itself, once it's removed from the package aseptically, is considered sterile. The formula inside is not, but there's nothing to say that from Health Canada or from the FDA that a skin antiseptic needs to be sterile, because it's the formula itself that's doing the killing of the microbes, the bugs, etc. And sterility can be contaminated at any time. So what you want to know is about good manufacturing process and good manufacturing, which Solventum thoroughly supports. So
excellent.
So no, it's
recall using Ioban a number of DuraPrep many times, and it's an excellent product.
That is why it also wouldn't be offered in a bottle.
Okay.
And I have had surgeons as well looking for a bottled DuraPrep formula, but it has to do with the formula itself on how we deliver it.
Okay, it's an excellent product. I've used it in urology for many years. I didn't realize that it helped with the adherence of drapes, so that's an actual bonus for sure. And I have a question because I see a lot more surgeons now looking at pouring iodine into wounds, or provide iodine prep. Sorry, I can't get it out tonight. I'm sorry. And it's inactivated in the presence of organic materials, which I've known for quite some time. And I'm just wondering, like, why do they continue to do that?
Well, that's a question you'd have to ask them. However, like I mean, the surgeon years ago in this little head for years and years, and he said the solution to patients dilute was kind of his thought pattern at the time. Fluid that has a skin antiseptic in it, but there are other manufacturers out there that do recommend seeing what their evidence is and seeing what they have to support.
Well, this is an amazing conversation tonight. Thank you so much. The more we can do to help prevent our infections, whether they're superficial or deep, it really does impact the patient's journey to wellness and recovery. I know we talk a lot about artificial intelligence, and so those are the types of devices that are being used now to kind of pick up these drainage, infective drainages that we're getting from our wounds. So I think anything we can do to help minimize that is always good for patient care and meeting our quality initiatives. Really shared a lot with us this evening. I'll have to go back and look at this archived video and some of the slides in greater detail. I also really enjoyed hearing about St. Martha's Hospital journey as well, giving me some ideas to think about with respect to maybe policy. We don't have one in our large center, and it makes sense that we should. So things to think about to try and impact practice. I do not see any other questions this evening in the Q&A or in the chat. Any closing comments?
If any questions do come up, I'm always available, and please reach out. We're happy to answer any questions and work collaboratively with you to better patient care. We're all here to do the same thing. Thank you
Thank you.
for having us.
And how about yourself, Kathleen? Any comments you'd like to make at the end?
No,
Actually-
thank you for the opportunity to share my story. I appreciate it.
Thank you for
Yeah.
Thank you for sharing it. And I do also want to extend a very happy belated Perioperative Nurses Week. Thank you for mentioning at the beginning. We will have this archived in terms of video accessible to attendees, and certificates will be sent out shortly by our IT webmaster, Troy, who's amazing. We rely on him quite a lot. Thanks for your support tonight, Troy. And also to Solventum in terms of supporting tonight's webinar for our members across the province of Ontario. We could not hold these webinars without our vendor support, and we really appreciate you investing your time and expertise to support our membership. Thank you very much. And with that, I will bid everybody a good night. Thank you again.
Thank you.
Thank you very much.
Thank you. Good night.
Good night.